Thank you for the opportunity to talk. I thank the organizing committee. I'm going to be very brief. I have no disclosures, but I feel like I'm talking about something that makes me feel like a dinosaur, but I am not, because most advocates of open aneurysm repair are equally passionate about endo, and we try to individualize the best procedure for each patient. In fact, if you consider us dinosaurs, you may regret that, because we may be extinct one day, and you may need us for open repair. The SVS guidelines for sizing of aneurysms and when to intervene are right there in front of you. 5.5 centimeters or more in males, between 5 and 5.4 in females, fusiform aneurysm, saccular aneurysm. Yes, indeed, EVAR is gaining popularity and is taking over open repair. But I think that there are a number of critical variables that interplay as far as your decision making. The first is the perioperative mortality risk and life expectancy. And if you look at this prediction model that has been published in part of the guidelines, you can actually determine and score for each patient what their mortality risk is based on the treatment, the aneurysm size, the age, the gender, and define the patient as being low risk, medium risk, high risk, or prohibitive risk. I would say that the high risk and prohibitive high risk groups are probably not in need of any kind of intervention, open or EVAR. Just like the EVAR trial 2, any patient who's unfit for open repair should not receive endovascular repair. The early and long-term results of open aneurysm repair and EVAR have been disclosed, and I think that it's very clear that there is a higher reintervention rate with EVAR, and the operative mortality is the downside during the first 30 days of open aneurysm repair. And this again shows you the reintervention rate being much higher with EVAR. How about anatomic suitability? Well, we used to talk about hostile necks, but now there are a plethora of stent grafts that are available for angulated necks, necks with thrombus, and so forth. So the limitations of EVAR are declining bit by bit. Anchors also do help with short angulated necks. The type and location of AAA is really important in your decision making. Is it an infrarenal aneurysm or is it a proximal aneurysm? And proximal aneurysms can vary. Primary aortic infections and mycotic aneurysms are clearly open repair is needed in these cases, but EVAR is acceptable in high-risk patients. Other indications for open repair include late EVAR open conversions, large accessory renals or a large IMA that you don't want to cover, and connective tissue disorders. We talked about ruptured aortic aneurysms. I think that most studies show no benefit to EVAR, but I think this is going to change over time. Only one study showed improved survival, 30-day mortality, which was the ECAR trial. And then the availability of FEVAR, BVAR, IBD endografts experienced in complex EVAR techniques, SHEVAR, sandwich anchors, and expertise in all these endovascular techniques are an important variable. So we just can't say that we want to do endo without having a significant experience in these techniques, because there are a lot of stent grafts available for a variety of aneurysmal variations. I actually prefer the left flank retroperitoneal approach for complex aneurysms in patients who are fit, and I think that in a lot of places in this world, fenestrated and branched endografts are not available, so open repair should be considered. and it allows you to select your proximal clamp site safely and allow for expedient repair of the pathology. There's meta-analysis shows that open repair mortality is equal to FEVAR in juxtarenal aneurysms. Yes, FEVAR is a favorable option in high-risk patients, but open repair remains a viable gold standard. I should mention one very important factor here, which is prevalent in the Middle East, that patients who are lost to follow-up after EVAR have a much higher mortality rate. So this is a really important variable, and it's a concerning one. So, in summary here, the European Journal of Vascular and Endovascular Surgery published the 2019 Clinical Practice Guidelines. In most patients with suitable anatomy and reasonable life expectancy, EVAR should be considered. And again, this word reasonable life expectancy is somewhat dubious because it doesn't have a number on it. And then its next statement is in patients with long life expectancy, again, we don't know what the range is here. Open surgical repair should be considered as the preferred treatment modality. And obviously, patients with limited life expectancy, AAA repair is not recommended. Not to just add another nail in the coffin here, abdominal aortic aneurysms, the NICE guidelines do not offer complex EVAR, and what they mean by complex EVAR is fenestrated grafts or branches or chimneys and all that, all these ancillary techniques to an unruptured AAA if open surgical repair is a suitable option, except as a part of a randomized controlled trial comparing complex EVAR with open surgical repair. Whether this is going to be disputed and modified, it remains to be seen. But in any case, it may be a blessing in disguise because our trainees are not getting enough open repair. In the US, now about half of the trainees get less than 5 open cases during their fellowship, which is really a travesty. So my final conclusion here is that for the foreseeable future, open aneurysm repair will remain an essential component of our vascular practice. And I think that your local conditions and geography determine whether you're going to do open or endovascular, straight endovascular or complex EVAR. Thank you.